to welcome you this morning to our Law Medicine Symposium, this year co-sponsored with the Center for Business Law and Regulation. We have some incredible presenters here for you today, which the directors of the two centers will be introducing in just a moment. I just want to let you know a couple of things. One is the proceedings that we have here will be published in our journal Health Matrix. In addition, you will be, am I on or not? In addition, you'll be able to pick up various materials outside if you haven't already. And there are a variety of people who will be here to help you if you have questions about anything that is going on. I do hope you enjoy the day. I'm going to turn the podium over now to Professor Jonathan Adler, who is the director of the Center for Business Law and Regulation, and he'll be followed by Professor Max Mehlman, who directs our Law Medicine Center. Thank you all.
Thank you, Jessica. Good morning, and thank you all for coming to our conference on corporate wellness programs, examining the question of whether wellness programs enhance well-being. Corporate wellness programs, as I think you all know, are quite the thing these days. Large employers seek to both enhance the well-being of their employees and improve their bottom line through the creation of various programs that are intended and hoped to encourage healthier behavior, encourage well-being among their employees. But over the last several years, we've seen questions raised about these programs, whether they actually save the money that consultants and others suggest they will, whether they improve the health of existing employees or perhaps merely substitute less healthy employees with healthier employees, creating a selection bias in who works at companies, and concerns perhaps that they are discriminatory in some contexts, that they disadvantage those who for health or other reasons aren't capable of taking advantage of certain programs or improving certain outcomes. Some have wondered whether or not wellness programs represent a replacement of the nanny state with the nanny corporation. Today we're going to hear from folks that both support wellness programs, think they are important, they are a positive step in improving the health and well-being of employees and people in the nation as a whole, as well as those that are their critics. And hopefully in the discussion and dialogue we have today, we'll learn a lot more about these programs, what they can offer, what their benefits are and what their risks are. And as Jessica already mentioned, we'll be publishing papers in this conference in Health Matrix that will hopefully continue this discussion. I think it's pretty clear that wellness programs of some sort are here to stay. Employers seem to like them. They are in some respects encouraged by various laws and regulations. And if we're going to have these programs, we certainly should care about what they do and care that they achieve the goals that we'd like them to achieve at acceptable cost. And so hopefully today we will learn a lot more about this and clarify our understanding of what these programs can do and how they might be improved. Just a quick note, this program is being webcast, both live and archived. For those of you that are watching the webcast, if you have questions or comments, you can email me at jha5@case.edu. I will be on my laptop all day and will be happy to forward questions to our speakers. People will also be tweeting this conference with the hashtag LawMed2016. So for those watching at home or perhaps watching in offices upstairs, please join the conversation that way as well. Without any further ado, let me turn it over to the person who really deserves the lion's share of the credit for today, and that's Max Mehlman of the Law Medicine Center.
Thank you very much. Actually, the people who deserve the lion's share of the credit are Nancy and Brian, who are our administrative assistants and who've done a terrific job of putting this all together. Welcome on behalf of the Law Medicine Center. As we are webcasting this, if you have questions or comments, we'd like you to use a microphone. There will be people with microphones. They can bring them around to you, so just sort of raise a hand. The format for the day is that we're going to have essentially two sessions, morning and afternoon, with a different group of speakers in each session. What I think would work best is if the speakers each give their talks and then we have time for questions and answers, except that Dr. Scanlon has to leave a little bit early, so we'll have some dialogue during the in between the different presentations, but we'll also try to leave some extra time for Q&A at the end of the morning. We're scheduled to go until noon, at which point we will have lunch for you, in classrooms that are behind there. We'll tell you more about that in a minute. And then we will resume at 1 o'clock at 1 o'clock to begin our afternoon session, and we will end promptly this afternoon because we have another wonderful speaking opportunity this afternoon after this conference. So without more, let me introduce our morning speakers. I'm going to introduce all of them now, and then they will be giving their talks one after the other. Our first speaker is Soeren Mattke, who is a physician and a doctor of science in health policy. He's a senior scientist at RAND, professor at the Pardee Rand Graduate School, managing director of the RAND Health Advisory Services, which is the consulting practice of RAND Health. He's an expert in wellness programs and was the lead author of the 2012 wellness program study, which was a report to Congress on the program uptake and impact and the evaluation in particular of PepsiCo's health and wellness program. And this report, which was published in Health Affairs, was the second most read article in that journal in the year 2014. Soeren will be followed by Dr. Michael Roizen, who is the Chief Wellness Officer at the Cleveland Clinic. You have more extensive bios for our speakers in your materials. Dr. Roizen is a prolific author and speaker. He is frequently an expert on television. Despite all of these commitments, he still practices anesthesiology and internal medicine at the Cleveland Clinic. And he is the Chief Wellness Officer, which was the first position of its kind in a major healthcare institution in the United States. He was named to that position in 2007, and he also serves as the chairman of the Wellness Institute at the Cleveland Clinic. Our third speaker is Dennis Scanlon, who is a professor of health policy and administration at the Pennsylvania State University. He is in the College of Health and Human Development. He's the director of the Center for Healthcare and Policy Research. His research focuses on understanding measurement, incentives, quality improvement, individual and organizational behavior change for improving healthcare outcomes, including clinical quality, patient experience, and economic efficiency. Our next speaker is Elizabeth Click, who is the medical director at Case Western Reserve University, assistant professor in the Francis Payne Bolton School of Nursing. Dr. Click created our faculty and staff wellness program and continues to direct that ongoing effort. Prior to joining our faculty, Dr. Click managed the wellness training program at the Progressive Corporation in Cleveland and also was a faculty member at the College of Nursing at the University of Tennessee, Memphis. So that is our morning lineup. Sort of to put in a nutshell how I sort of conceive the day, we often urge our law students when they graduate and start their careers that they should try to do, we hope they do well by doing good. And today we're going to think about whether we can do good by doing well. So without more, Dr. Roizen. I'm sorry, Dr. Mattke.
Max. Good morning, everybody. When I saw the lineup and the titles of the talks behind me, I figured I gotta change my talk a little bit. I was going to talk a lot about the Department of Labor study and the PepsiCo study, but I think we will hear a lot about evidence. So what I thought is, in light of the afternoon, I will talk a bit more about what we know about incentives and how they work, how they don't work, because they have become one of the most contentious topics in workplace wellness. Basically, what employers are struggling with is that they have these sometimes well-intended, sometimes not so well-intended wellness programs, and people tend to ignore them. And so they believe they can only get their employees to actually take part in these programs if they create incentives and expose them to sort of risks, penalties, rewards. But then there's this contentious legal issue. There's kind of ways of laws and regulation that applies to different parts of the wellness program, and the afternoon speakers will talk a lot more about it. What I want to talk about is if we actually want to use all these incentives, what do we know about whether they work or not? Because in a sense, this is the ultimate question. We don't really have to worry so much about legality if incentives have relatively limited impact on participation, costs, and health outcomes. So that's what I wanted to cover today. I welcome questions. It's a relatively short presentation for half an hour, and we are a small group, so if you want to jump in, feel free to do so. If not, I'll just go through and answer questions at the end. So the data sets that I use to answer that question is a 2012 national survey of employers that we have done for the Department of Labor. It's really a nationally representative sample. It's a pretty large survey of 3,000 establishments. And we had very detailed questions on configuration, participation rates, incentives, what is being incentivized, how, and so on. And then we had a large employer that shared its data with us, and they had done something us researchers really love. They had done a little natural experiment and had introduced a $600 non-participation penalty for smoking cessation under their wellness program. Only for smoking cessation, not for the rest of wellness. And so you have a nice natural experiment in which you can use the smoking cessation participation rate and compare them against the other wellness program participation rates. And that's just a nice little natural experiment that we so love. So here's what we found. And bear with me, there's about $50,000 worth of science in that slide, so it's actually not easy to understand, but it will tell you a lot. What we did is when we got the questions back from the survey, we had very detailed information on what exactly it is that different employers in our survey offer under the heading wellness program. And we grouped loosely into three boxes. We grouped them into, okay, here are the screening things where they basically just look for health risks like HRA, glucose, blood pressure, BMI, and the likes. We looked at, here's what they offer in lifestyle management, so where they address health risks but not manifest diseases. And here's what they do in disease management, so managing manifest conditions as opposed to preconditions. And then we used a statistical technique called cluster analysis, and please don't ask me about it, and showed kind of how these programs are configured. And we found basically 5 archetypes of wellness programs in that study. So we have here the yellow, and the further you go away from the center, the more likely it is that sort of the area that's being enveloped by these lines encompass the different components. So you have here the yellow piece, which is called the limited program. You can see they usually do an HRA and then a little bit of screening and a few interventions here, but really not that much. So that's what we call limited because it's really, really bare bones. You have the opposite, which is the comprehensive wellness program. That's the green line here. You can see they do pretty much everything here on the screening side. Have a lot of offerings for chronic conditions and have a pretty rich set of interventions for the glucose management, fitness, nutrition. So that's kind of the other bookend of the universe of wellness. And then you have a couple of subtypes here in the middle. There's one that we call screening focused, the red line. And you can see here, they're pretty up here with the comprehensive with respect to screening. But then they go pretty narrow with respect to managing. So it's pretty much they look for stuff, but they don't do much to address those. And then you have, again, the opposite. You have the intervention focused. You can see here the purple line. They don't really do much screening, but they're pretty strong here on the intervention side for chronic conditions and also here for preventive interventions. And then you have lastly the prevention focused one. Almost nothing here in the chronic disease space, the blue dotted line, but a lot in the screening and a lot here in the health risk component. So those are kind of 5 typologies. It's somewhat of a simplification, but if it gives you a good sense of what are the animals of wellness programs that are out there. So why does this matter? We looked at how these programs are related to participation rates as the employers report them. So here, the median participation rate for the employers, self-reported, I might add, is about 40%, which tends to be about twice of what the real-world measured participation rate is. So 20% is a more typical number. But what we do see here is that the comprehensive programs have by far the highest participation rates. And then it drops off prevention programs, which is kind of how many people understand wellness, which is very health risk focused, have the lowest participation rates, and then sort of in the middle. So keep that in mind. If you have a rich program, people tend to come. And then we looked at, from what the employers told us, do programs that offer incentives have a higher participation rate? And yeah, we see that. So if you have a program that has no incentive component whatsoever, the reported rate is about a third. If you offer any reward, it's about half of the eligible people participate. What's interesting, if you offer a higher reward, most of them were kind of token rewards, like $20, $40. But even if you go higher, above $100, the participation rates are really not that different. Only if you start bringing out the sticks, then participation rates go up. And our economists can probably explain why that is, but that's interesting. If you offer penalties of equal value, you tend to have a greater effect on participation rates. Now, we said, well, richer programs tend to drive participation, incentives drive participation. The obvious question is now, how can you disentangle all of that? And of course, we have enough statisticians that could do that. And so what we did is we tried to attribute what portion of the predicted participation rate at an employer is due to an incentive effect and what is due to what we call a configuration effect. So, and here's what we see basically for the comprehensive program, the predicted overall rate is about 73%, and about 46% of that is incentive effect, and a third is configuration effect. And that number here, 27, around 25%, is typically the configuration effect across the board, except interestingly for the preventive programs. Again, those are the ones, if you go back, those are the ones that do a lot of screening and a lot of lifestyle management, but nothing here in the disease management area. So the preventive programs tend to require the biggest incentives. So for them, the incentive effect is actually much, much larger than the sort of the baseline configuration effect. And that tells us if you have a very very lifestyle-focused program, you really need to force people in it because otherwise they won't come. Again, if you have a very comprehensive program, they tend to come even on their own, but you can really boost participation with incentives. And mind you, these are not strong incentives. At the time of the survey, high-powered incentives, such as like up to a third of cost of coverage, were really, really rare. So we are talking mostly about $20 amounts, $50 amounts. Some were 100, 200, but it's really not in the area that many would consider like punitive incentives or penalties. So what about the incentive effect in that? Please.
Just a small point of fact question. How many corporate wellness programs did you get responses for? You may have mentioned it back.
The sample was 3,000 establishments. We had a participation rate of, I think, 27%. So 600, give or take.
Excuse me for one second. Do we need microphones for audience comments to have it on the web? Do we have them? Okay. So if you can hold your questions and comments so we can circulate the microphones, but as Dr. Mattke said, if you have them, just raise your hand. Thank you.
So here's where we looked at actual participation data for an employer, where we had this natural experiment of introducing a $600 penalty here. So this is where they restructured, and this is where they introduced the penalty. And yep, the participation rate went up slightly, and what we estimated in the difference in difference model, I'll spare you the details, is that the participation rate went up by 8.5 percentage points, sorry, it should say percentage points, after the introduction of the penalty. So not a huge effect, considering that $600 actually is a significant penalty. So what does this all mean? First, I do want to go back to our research findings from the report to Congress and the PepsiCo study to put these incentive effects into perspective. So overall, our research shows that there is a relatively limited potential for cost saving under wellness programs. And here's a nice little back of the envelope calculation. So cost of coverage for an adult is about $5,000, give or take. I did a little rounding to make the math easier. There was a study done by Bolnick et al. That estimated how much healthcare costs could come down if we were perfectly healthy. If we kind of all looked like Chippendale models, spent our days on the treadmill, ate nothing but kale, grains, and red wine. So in the perfect world, of course smoking, I don't want to start with smoking. In the perfect world, this is how much money you can actually save on average in an employed population. It's about 18% of the healthcare cost and about $900. So that's the money at stake for a wellness program on average to save. But our data from the Department, excuse me, from the Department of Labor Study shows, of course, that we won't look all like Chippendale models and drop the cigarettes and all other bad habits. We eliminate the risk factors at a range of about 10 to 25%. So that's not bad. That's not bad at all. But of course, it doesn't eliminate the risk at all. It just eliminates a tenth to a quarter of the risk. So if you relate that risk reduction to savings, the savings from the actual possible risk reduction is about $90 to $225 per year in a typical employed American. So that's roughly the money at stake here. And incidentally, our findings show that with little confidence, wellness programs save about $150 per year, which falls kind of right into the middle. And we can say with great confidence that they do not save more than $350. So it seems to all kind of work out. Please.
A friend studied your study in great detail.
Wait for the microphone.
Stop. We have lots of people listening to this, watching this on the web, so we just want to make it part of the experience. Thanks.
A friend of mine studied the congressional report in great detail. He said that the net cost and versus savings was for every dollar spent on wellness programs that you analyzed. I think there were 600 or 900 employers you studied in that study. You got 25 cents in savings. I don't know if that's an accurate figure then, but what is it now? What's the cost versus savings?
The 25 cents actually comes from the PepsiCo study, which I have on my next slide. For the labor study, we did not have information on cost of programs. So that's kind of gross savings before we deduct cost of program. In the industry, the sort of word on the street is that a wellness program costs about $150 per year per employee. So from that, it's roughly break even. But in the Pepsi study, we show that it actually does look worse.
It does what?
It does look worse. So this is the 25 cents on the dollar. There's another question in the back.
What you're talking about, though, is simply the real dollar impact, right? You're not talking about the employee morale, potential benefits, or the employee retention factors?
Yep, that is healthcare savings. In the Pepsi study, we looked at absenteeism. I'll get to this. I think, yes, once the numbers came out that on healthcare dollars and even on absenteeism, you can't save money. The vendor community started to argue, but what about well-being, retention, morale? Things that may be true, things that are really hard to measure, and things that are really, really hard to quantify. And I have not seen any data that would present the case that having a wellness program has a measurable effect on morale or retention in natural units, let alone an attempt to quantify that in so financial benefit. I mean, my answer is always like, if you spend money on these programs, you want to expect something in return. And if you cannot quantify what the return is, it's kind of a questionable argument. I mean, Rand, to my chagrin, still has a wellness program. I keep telling them, give me the $150. It would make me a lot more happier and morale and motivated if you just give me the money and do away with this silly program. But that's a different, that's a different story. Because this is real money. It's $150 for a low-income worker. This is actually sort of a tangible amount, and I think many people might take it in a salary increase as opposed to in a wellness program. Please.
In regards to participation, have you taken into consideration the population education level, union, non-union environment?
We have in one study, it's a 2014 report for labor. To our surprise, there wasn't really much in there. It didn't really matter like whether someone was management level or laborer or union, non-union. Surprisingly little. I don't recall all the details, but there's a report on our website, 2014, that looks into very granular participation analyses. And there's another question.
Good morning. Did this also take into consideration the costs of employers having to hire people to, enforce these programs within the businesses and corporations?
No, this is literally gross savings, less healthcare costs. This does not include the vendor cost, nor the cost of running the program from internal resources. So, since I get so many questions on that study, let me just go through that slide because it might answer some of your questions already. This is from the Pepsi paper that came out in Health Affairs 2013. There we looked at their overall program over 7 years, so it's one of the longest standing wellness programs. And we found that of all the program participants, if we lump all of them together, we estimate a $30 per member per month savings for wellness program participants. Again, this is literally savings net of vendor cost. So, but if once we broke it apart, because Pepsi has sort of a lifestyle focused component and the disease management focused component, our data showed that almost all the savings come from management of manifest diseases. So $136 per member per month from those guys, and basically zero savings from the participation in the lifestyle program. And then we did the famous return on investment analysis. I don't have it here, sorry. But that showed that if you look at those savings against the cost of the program, the intervention returned 25 cents on the dollar if you look at healthcare cost only, and about 50 cents on the dollar if you look at healthcare cost and absenteeism. And that's the number you were referring to return on investment. And again, that's the overall return on investment, but of course the lifestyle disease management program does return money just because you're saving so much on very few people. So what does this all mean? Program uptake remains moderate, so if the median rate is about 40% if you ask employers. The actual participation data, if we look at the company's records, tends to hover about 20%. That is a pretty stable number if you look at various corporations. Incentives do work. You get a 20 percentage point increase with rewards based on the survey data, and twice as much if you bring out the sticks. So incentives drive participation. Lifestyle type programs, which is kind of what people typically think of when they say wellness, have a very low participation rate unless you bring in incentives. And the power of incentives, even of pretty strong incentives, doesn't really drive behavior that much as we think. So 8.5 percentage point, about a third relative increase in that smoking cessation study. And if you have a comprehensive program and an incentive to go with it, you tend to get the highest participation rates. So if you build a nice program and bribe people to coming, surprised they are coming. So what does this imply? A good program begets good uptake. Shouldn't be surprising, but for many it was. I would say it also shows that high-powered incentives primarily benefit the vendor of these programs because they typically charge per participating employee, but they do not have to bear the cost of any incentives. The cost of the incentives are paid by the employer if it's a reward, or the employee if it's a penalty. So if I were a vendor, I would tell people to really bring out the incentives because they don't cost me anything and every extra participant brings me any extra money. We also think that carpet bombing has a poor return on investment. We've seen these broad programs that are very comprehensive and target a lot of things. They tend to be a waste of money. I can't speak to retention, morale, and the like, but it's hard to make a business case for them. So what does this mean for wellness? We think there's three considerations if you want to continue wellness programs. And I keep saying our results do not say it is a dumb idea. Our results say you cannot expect to save a lot of money. So what we say is target higher risks, so people with prediabetes, people with manifest conditions, and give them a robust intervention. So not like flyers in the break room and a few intranet broadcasts, but really intense interventions to target higher risks, so narrow and deep. Leverage public health type interventions for the lower risks. Like if you have things that can be addressed with advertising campaigns, with using community resources, with changing in the physical environment, like making stairways walkable. Like Harald and I discussed this morning that we wanted to take the stairs in our lovely hotel but couldn't find them. So we had to take the elevator for 2 flights. So there are lots of things that are really, really cheap and where the costs do not scale with the number of participants. Like if you take out sugary drinks in the cafeteria, that doesn't cost you much, but it could actually have a big impact. And then lastly, I think there's a general principle that should govern wellness, that is, do not harm. And so avoid cost shifting through incentives, because with these high-powered incentives, I think, given our data, that really is what they do. So thank you much. I think I have a few minutes for questions, and then
I think we have questions now, and then we'll have more time for questions and comments later.
So, since I have the mic, I'll take advantage of it real quick. What do we know from the data about 2 possible effects? One is whether or not reported participation rates accurately reflect what people are doing. So, for example, if to get participation credit for a particular weight loss program or a gym, you have to use the employer's provider, but you have a gym near your house, the incentive might affect your willingness to switch gyms, but it might not actually affect whether or not you're engaging in the behavior. And then the other effect is some folks have postulated that over time you see self-selection by employees, that employees leave employers that have structured incentives or penalties that they don't like. And so you're not actually, while the employer may be saving costs, you're not improving the wellness of individuals, you're just replacing less well or less participating employees with more participating employees. From your data, do we know much about either of those two possible effects?
Sorry. Very valid concerns, but we have no data on either of those questions. Please.
Thank you very much. Fascinating presentation. Could you tell us two things? One, how is RAND Corporation committed to the work that you're doing? Generally, is it a department? Are you one of a kind? And with a 5-year forward look, what will you be doing next? What other research in this field do you anticipate doing?
Well, RAND is a think tank, so it's an independent policy research institute, but we are fully externally funded. So it is basically, we have to find money from sponsors to do our research. I sometimes describe it like it's a high-end escort service, so we do what the clients want, but it has its limits. At the moment, there is not a lot of money to study wellness, which I regret because there are many questions still open. But the corporations are no longer that interested because they believe the numbers that we got from Pepsi. And for the government, I think most of the questions they had were settled. So at the moment, we have looked for a while, but we haven't found an interested party that would fund further research.
Thank you.
So as a wellness professional, we are moving away, we've been shifting our focus from focusing on ROI, we're focusing on employee well-being and overall the overall view of that employee. But I would like to hear, if we have a minute, Dr. Roizen's views on you saying, Dr. Roizen's views on you saying that programs do not save a lot of money. Yeah, there's a date going here.
I don't know if you want it because I'm going to cover it in the next area, but if we had known his data before we started, we wouldn't have developed a program that saves a ton of money now, which I will show, and that promotes health, and that but the points he has made that are really strong in our data as well, the more comprehensive program and the better designed the program and the larger incentive, the higher the degree. And you'll hear in my presentation actual data. We don't have any, if you will, responses from people. We actually have data on their medical costs and their illnesses because that's how we do it. We don't have, I can't ask participation rates and say, do you participate or not? Because everyone will say they participate and it doesn't mean anything. So we actually get real data on it.
So one more question and then we'll go on.
I want to ask a quick question about, you said you're a high-end escort service, and I want to ask a question about your payer, Congress in this case, who happen to be paying for escort services, it seems. So I think a question will come back throughout the day is that we have a whole variety of different programs, and oftentimes the devil is in the detail, right? How exactly you devise a program, whether you focus on high-risk groups, as you said, whether you do it broad and narrow. There are all sorts of different implementation options. Now, you've described, you looked at 600 roughly employees. There's the National Business Group on Health has a survey, Kaiser does a survey, but there isn't really any systematic reporting on what kind of programs exist. Did you pick up any kind of reaction that Congress would be interested in having more systematic evidence gathering, which should really inform a lot of policy here? Or was this really a one-off report to say, let's see what we're getting out and we'll leave it there? Because to me, it would just seem this raises a whole lot more question than it settles. For the sample that you had, there's a clear picture, but then there's a lot of nuance in there that you would really, I think, want to explore in more detail. So have you picked up any kind of reactions from the government side to say we want to work towards more systematic reporting?
No, honestly. The initial study was a mandate of the Affordable Care Act, so it just had to be done, and then there was some follow-up work because labor said, you have collected so much data, so let's do a little bit more research to go deeper into what you have than what we could do for the report to Congress. But again, many believe that the most important questions have been settled, and so I don't really see great interest in doing more research. And I would personally be very interested in getting sort of a more granular picture and into what works, what doesn't work. And you're probably right, there are certainly good wellness programs out there, but there are a lot of programs that don't work out there as well.
Thank you very much, Dr. Mattke. Again, there'll be a chance for more conversation. We hope at the end of all of the presentations.
Hope, since it's gone out, let's see if we can get it. What I hope actually, Dr. Mattke, and I'm going to address him first in this, if you will, is that you can use the Cleveland Clinic data and the data we have spread to other 40 corporations where we really have actual data on people, on their medical costs and their disease incidence and prevalence, to argue for keeping RAND in business and studying better things on this area, because this is an area that I believe we would never have started were your data evident when we started it. So let me go and tell you why we did this. And so I have three actual things I want to say, and I have about 3 hours worth of slides to do in 45 minutes, so I'm going to beg your forgiveness and not take questions till the end. Why the Cleveland Clinic started a clinical wellness institute when all other academic institutions hadn't either started it or didn't succeed. That is, they had failed, like, if you will, reported earlier. Second, some fun understandings that will help you and that helped our Cleveland Clinic caregivers change and make successful, healthy behavior change. Just to give you the idea, and I'll give it to you now, 95% of our well people participate, 64.8% of the people with a chronic disease participate. So our participation rates, those are actual participation in disease, in if you will, to get to what we call 6 normals. And then I'm going to give you that specific data about the outcome, how much money we think we are saving every year based on competitor organizations, based on our trend line, and then we'll actually show you some of the effects we've had on the 40 other corporations. The compelling case, that is why we did it. It's the legacy of Toby Cosgrove, because he said and saw this from the Congressional Budget Office. This is a 2010 construct of the healthcare, of the GDP and federal spending for the next 70 years. As you can see, the blue line is everything non-in health, assuming a 2.5% growth rate in GDP. That goes down over the next 70 years. There's only one bump around 2030, which is the baby boomer Social Security bump. The red line is what costs us social programs. It's what costs us, in fact, defense spending. It's what costs us innovation. It's what costs us, in fact, everything else. It is healthcare spending, just in Medicare, Medicaid. It doesn't even include the Champus program. As you can see, that goes up in a steady fashion, and that erodes everything else America wants to do. The reason is clear. The chronic disease incidence. If you will, when I started practicing in 1974, that dates me. The bio is a little old. I'm 70 now. My real age is 50, though. But in any case, there were 2.2 million type 2 diabetics. We spent an hour on it in medical school at UC San Francisco, not very much time. If you look at it recently, there were 29 million diabetics in the US. That we actually treated 16.9 million of them. We spent 1.5% of GDP treating that group of people. The prediction is, in fact, that we go to 120 to 180 million, or the CDC would say 220 million, with a 30% increase in the population. We are not unique in type 2 diabetes, if you will. Total hip and knee arthroplasty, there were 67,000 of them done in 1974. Recently, about 1 million. The prediction is a 6-fold increase, with, again, only a 30% increase in the population over the next till 2050. And if you look at the rest of the world, we have exported our bad habits extremely well. China had in 1980, you're supposed to laugh at that, darn it, guys. China had 1% roughly, or a little less, in diabetics. The CDC, our CDC, and their CDC are equivalent, participated in the study of 100,000 Chinese, roughly 100,000 at that time. Recently, they repeated it. It was 11.6% of the Chinese population is diabetic, the same growth rate as we have. In fact, it's accelerated. Oops, Darren. Do you have a piece of tape, Dave? It doesn't screw in. It doesn't screw in? No, anyway, so that's why I said a piece of tape. Anyway, if you look at it, and in that same study, 50.1% of the Chinese were pre-diabetic. What did that mean? They have a total population of 607 million at risk for diabetes. So chronic disease is rampant. If we looked at the Abu Dhabi population, where we have excellent data, if you look at the Indian population, where we have less good data, it is the same. It is roughly 67% of the world's population is at risk of chronic disease in a very short period, and diabetes is a leading, type 2 diabetes is a leading cost. If you will, what are we spending? Well, if we spent the same amount per person in 2050 as we do now, we would spend 15% or $4 trillion. That's with no new therapies and no aging of the diabetic population. Both will happen. That obviously is not doable. The diabetes, by the way, in China, even if they did it now, if they just treated their diabetics the way we do, they would have to, with their costs, they would have to increase to 700% of their current total medical spend just for their diabetics. And that's because most of their diabetics don't get treated. So in 2050, we will use 15% of our GDP on diabetes if we don't change. We'll do it for osteoarthritis care too. We'll do it for dementia care too. We'll do it for cancer and post-cancer care too, and post-heart attack and heart attack care too. If you add those up in food, you don't have to worry about having a urology department, a sports medicine department, or a pediatric department, because there's no money for that. There's no money for defense, education, social programs, research, or manufacturing either. So the compelling rationale to stop the influx of chronic disease is we can't have society without it. We can't have social programs we care about if we don't stop the influx of chronic disease. So Toby Cosgrove said in 2007, if we want to continue to lead in healthcare, that is the Cleveland Clinic, we have to stop the influx of chronic disease, because America will either get severe rationing, and we're beginning to see that now for drugs, or we will get rational. You can see that from the Kaiser data. This is Kaiser Foundation data for the last 16, and this is the payment, if you will, by the individual out of pocket. It's gone up threefold in just 16 years, from $1,500 to $5,000. And the payment by corporations for insurance has also gone up threefold. Who does that hurt? That hits the lowest income employee worse. And in fact, in just 15 years, every dollar of productivity from American corporations has been used by medical costs or medical insurance costs because of the influx of chronic disease. And, if you will, it is the cause of income inequality. More than every dollar of disproportionate income change is accounted for by medical costs or medical insurance costs. So if you care about social programs, you care about stopping the influx of chronic disease. And like the country of the world, our costs at the Cleveland Clinic for our employees were going up in the same fashion. And when you do it by a dollar, we're paying $305 per employee per month. That's an all-in cost, all administrative costs, all HR costs related to wellness, everything is included in that PMPM fee in 2008. So it's a little high based on national standards. It's not high based on hospital standards, but it is a total, every administrative. So my salary is in that fee, even though I don't directly involve in that. If you look at the projected numbers for the next, till now, thank you. The projected numbers, as you can see, go up steadily. And in fact, this year we would have spent an additional $395 million for our 48,000 employees, 101,000 total employees and dependents. That we thought was in a fee we could not afford We would not be able to do the innovation, we would not be able to do the growth, the new building, the new programs, or even give, as you know, the Cleveland Clinic has a minimum wage that is much higher, and given all of our minimum wage employees a raise this year, a substantial raise that is much higher than the minimum mandated. The CDC made it easy for us because they reported both in 2007, and this is the 2014 data, the 2014 New England Journal report, 2012 data, that chronic disease management, in fact, costs 84% of all medical costs, and 67% of those are now in the working population. In the 1950s, we used to spend 50% of a total employee's healthcare costs in their last year of life. It's no longer that way. It's 15% because it takes so much to get there. But they said in 2012 that 75% of this was four things: tobacco, food choices and portion size, physical inactivity, and unmanaged stress. Those, as you'll notice, are under our control. So that's what the Cleveland Clinic attacked, and attacked with its employees, and I'm going to show you the results later. But let me go and show you, why are we twice as expensive as Europe? Because we have twice the, or Canada, we have twice the chronic disease under management as Europe or developed Canada. We have 100% more high blood pressure, 110% more heart disease, 140% more type 2 diabetes, and 800% more stroke at the same age. And we're getting worse. We got progressively worse. Calories consumed in the U.S. stayed the same from 1858 to 1983, when the culture changed and we said it was okay to have a Starbucks on every corner. It was okay to eat anytime, any place, anywhere. You've got snacks here at all times. That's not a wellness activity, if you will. Because, in fact, we started gaining 2% of calories eaten per year. But that's 2% compounded annually. So it's 40 more calories in 1985, 80 more calories in 1986, et cetera. The good news is we stopped in 2000 at 400 more calories per person per day. You'll see what that has done to our BMI. And physical activity has decreased to 0 in 47% of Americans. That is, 47% of us are willing to say we do less than 10 minutes of walking any one day of the week. That's up threefold in just 20 years. The black lines are the Nyhanes 2009-10. The blue lines are 1988 to 94. So it doesn't matter whether you're a man or a woman, doesn't matter whether you're employed, unemployed, doesn't matter whether you're Hispanic or Caucasian or Asian, 50% of us are doing no activity, 0. What has that resulted in? A cost increase, not a dollar cost, much greater dollar cost, but an absolute, as a percent of GDP, increase of 50% from 1990 to 2010, and a body mass index of 0.37% per year. Roughly, each American is 1.25 pounds greater than they were the year before. Let me give it to you as a 5'7" woman. The average 5'7" woman who's 40 years old now weighs 25 pounds more than the average 5'7" woman who was 40 25 years ago. That's a steady gain in BMI. So that's the compelling case. And not only is it a U.S. case, it's a world case, because we have done the export so well that almost every country, with the exception of Japan, now has America's problem. We don't manage stress, we eat too much inexpensive, addicting food, and do too little physical activity, and that reduces all of our standard of livings due to medical costs and medical insurance costs. But we know the answer. What really matters, we got from the Nurses' Health Study and from some Swedish men's study and a few others. If you do 5 behaviors in the Nurses' Health Study, you have only 10% of the risk of a chronic disease over the 28 years of all the people who did even one abnormality. And the problem is that only 4% of the nurses who were elderly, 3% of the young nurses, did healthy behaviors. In the Swedish men's study, it was an 87% risk of chronic disease over the 18 years of the study, but it was, in fact, only 1% of those Swedish men did the 5 healthy behaviors. That's why 96 to 97% of Americans, reason there's a data gap there, 96 or 97, we only have 2 data points on it, enter Medicare with either an untreated or undertreated chronic disease. So if you do 5 behaviors, you have much less risk. The Cleveland Clinic didn't want to look at behaviors because we can't look at self-reported data. We wanted objective lab data. So tobacco-free meant no cotinine in the urine. Cotinine is a tobacco end product. Waist half height, we said BMI or waist or body fat would be an acceptable measure. 30 minutes of physical activity a day, we turned into measures of type 2 diabetes. Mediterranean diet, we turned into measures of LDL cholesterol. Only a little alcohol and managing stress, we turned into blood pressure. And those are the monitors that we do with our employees and their dependents. Nyhanes updated the data, and the Nyhanes data from 2010 to 16 is how many in the U.S. had 4 healthy lifestyle characteristics. They did 30 minutes of physical activity 5 days a week. They had a healthy diet on 6 of 12 criteria. That is, any 6 of the 12, if they did it, they passed. They didn't smoke, and they had healthy body fat. At age 20 to 39, 3.9% of us do it. Age 40 to 42, 2.4%. Age greater than 60, 0.6%. We are the cause of the problem. And so if you look at it, we believe that, in fact, the most important question in health today is the one that no one is paying, as Dr. Mattke said, to study. That is, how do we get more people to do the 5 healthy behaviors? Because without it, we as a country, our economic status is dead, and the world is, in fact, in the same trouble. Because we will either get rationing, which will, in fact, really make income inequality much worse, or we will get rational, and that means we have to change behavior. So the Cleveland Clinic formed a Wellness Institute. This is the component. We're the only one with a for-profit and a not-for-profit arm. This is where employee wellness, and it took everything in HR, put it there, and kept the costs with us so that we knew what the costs would be for all medical care, and we charge our employees, if you will, we charge our own insurance plan, what we charge, in fact, commercial insurers. We upgrade it every year. That is, just this year, our pharmaceutical costs went up 18%. Those get passed on to the health place, and so we keep track of that. So that's the real, if you will, compelling case for why we had to do this. If we don't do it, if we don't stop the influx of chronic disease, then the country's, in fact, social structure comes unraveled. Let me show you some of the fun understandings that can help you make why we did this to sustain behavior and how we got people motivated. So what we did is, for example, when we talk about meat, trimethylamine oxide in the meat that comes from the bacteria in your gut means you have to have extra virgin olive oil, roughly 700 calories of it a day, or you shouldn't be eating red meat or egg yolks. Why is that? Because carnitine, lecithin, and choline in more than 96 grams of red meat or yolks in a week, or 200 grams of pork, changes the bacteria in your gut to produce trimethylamine or butylbutane. That goes to the liver that produces trimethylamine oxide, and trimethylamine oxide causes more inflammation in your body than a blood pressure of 250 over 110. That's a blood pressure that no one would allow to be untreated. But we have to give that understanding, and you have to get it emotionally. People have to understand that this is what's happening for them to say, I'm not going to have the burger every day. And that's why we use videos and a whole bunch of other things to show what a heart attack is and to show how this process is made worse by inflammation. And I'm not, for time's sake, going to go through that, but just to say you have to get the emotion of the employee. So the point that Soeren made, there are different programs. If you don't do a good program, if you don't grab your employees emotionally, If you don't make it as much fun as Disneyland, then you fail in the wellness program, because it's got to be something the employee wants to do, not is forced to do. So most is saturated fat? No, the reason is, but we went through it. And most employees, most patients don't know that if they have breast cancer, that the more fat they eat, the more they're going to die and get a recurrence of breast cancer. And they don't know that if they gain weight, they're going to get a recurrence or a higher risk of mortality from breast cancer or prostate cancer. And that just by switching to extra virgin olive oil from saturated fat, they decrease the breast cancer recurrence rate by 62%. Or that by adding 2 fruits a day and 30 minutes of physical activity to whatever they do, they reduce their prostate cancer recurrence rate by 50%. But that's the point you've got to get. And it's part of the wellness program. You've got to get people emotionally involved in it if you're going to get them to change behavior. There's another film that I'm skipping. Because most of us think we hit our peak quality of life of 25 to 35, and it's all downhill after that. And if you do nothing about it, that's right. That's where your genes will take you. But my favorite study of all is of Harvard physicians. This study started in 1954. It ended when the last one died a few years ago. But you look at their IQ. Their IQs go down linearly. This is the same group followed. Their IQs go down 5% every 10 years. Like every other function, your kidney function, your lung function, your liver function, everything goes down 5% every 10 years, except for bone mass, which goes down 10% during menopause in women. So you see, you should choose a younger doctor. But in fact, when you look at the error bars, a bunch of them go through no change. In fact, 25% of them in that study don't have any change. And that's really what you have to do. How do I motivate my employees? How do you motivate your employees to do the behaviors that get no change in IQ or no change? And it really is that what you're trying to do is tell people that after the age of 25, once they start working, whether they're at their top of their performance curve or at the bottom, are their choices. It's a family of curves. But which curve you're on is to a large degree your choice. So can you get younger? Yes. And it's not just prevention, but it's reversing, if you will, chronic disease or aging first. And this is one of the patients that was most impressive to me. This is a guy who came from Hopkins after being refused for cardiac bypass surgery there in 1996. And he came to the Cleveland Clinic asking for it. This, where white is where blood flows. This is the left anterior descending artery, and you see it's ratty. He got refused because there was no good artery to bypass. 2, that is, you need plumbing to put it into that's healthy. But he couldn't, and in fact, he got turned down at the Cleveland Clinic, and he asked his doc, Dr. Esselstyn, what am I to do? Am I just to die? I can't walk even 5 feet without chest pain. And Essie said to him, we'll eliminate a few things in your diet. You can walk 10,000 steps a day. You can meditate 10 minutes morning and night. And if you smoke, you can give it up. And the guy said to him, I can't even walk 5 steps without pain. How can I walk 10,000? And Essie said, you've got a new job. Instead of your current job, your job is to walk 2 steps 5,000 times a day. And this is the curve, same x-ray machine, 2.5 years later, and you pulled plaque out of his coronary arteries by doing that. And you guys can do that too. Chronic disease is not only preventable, it's reversible. This is the same machine, same guy, and you'll notice he developed a lot of other collaterals that he opened up too. You can do this, but you've got to get the emotion and the desire of your employees to do it. And it really is changing genes, but I'm going to get back to that later. So the compelling case is that without it, we as society don't live. That you can make it fun, enjoyable, and educationally entertaining. Let me now show you the specific data for the Cleveland Clinic. This is our smoking rates. It was 15.4%. This is cotinine data. This is not self-reported. It is now 5.2%. Yes, we put an incentive in. And we learned an important lesson. Before we had this program, we reimbursed smokers to quit 83 to 89% of what we charged. In fact, they had to pay, like every other program for smoking cessation in the state of Ohio. It was not covered by insurance in 2004. So they had to pay for it, and we reimbursed it 83 to 89% because the Cleveland Clinic wanted to encourage no smoking. We had 100 people sign up in 4 years. The day we made it first dollar free, no charge at all, 400 people signed up, 362 of them got smoke free. So you can do it. But we learned an important lesson. The programs have to have no barrier to entry or be free. So we made curves free, fitness center free, yoga classes free. Again, data I'm going to show you. We increased the utilization of the fitness center 15-fold. Even our cardiac surgeons, all of whom earn over $150,000 a year, used it 5-fold more. And you say, were the cardiac surgeons so cheap as taking away an $18 charge got them to use the fitness center? And the answer is no. The culture changed, and that's an important point. They knew they were expected to be well, just as everybody else. And yeah, we did take out sugared beverages, and Pepsi called us. The CEO to CEO called Toby and said, you're going to lose $675,000 in subsidy we give you for your educational programs by taking out sugared beverages. And Toby said, it'll be the best $675,000 we ever lose. What happened 3 months later, they were drinking water, and there's no change in our educational program subsidy. So, yeah, it did fall for 3 months, but that's all. And we took out fryers. We have 43 fryers for sale. Anyone wants to buy them? They're still there. And in fact, and by the way, we didn't change the name on the food other than putting parentheses. We had to go through 85 taste tests to find baked chicken that tastes absolutely as good as fried chicken. And all we did was put the fried in parentheses until this year when we changed it, or last year we changed it back after 4 years to reflect baked. Our employees have lost 445,000 pounds. That's the 34,000 that have been linearly followed. That is not self-reported weight. That's weight in the physician's office, as 97 to 98% of our employees use Cleveland Clinic for their medical care. That's actual weight. By the way, what is this room? This is the 8 p.m. version of this room. If you can tell me what it is was at 12 noon, I'll give you something. A book? This was McDonald's at 12 noon. Toby cared enough about getting McDonald's out that the Golden Arches were there at 12 noon, and you couldn't even smell a French fry at 8 p.m. that day. Because he, on his first move, as you know, in 2004, he tried to get McDonald's out, and they wrote him a nice letter saying their contract was longer than his, so he had to wait 12 years, but they are out. Our BMIs have gone down 0.5% a year. It is cumulative benefit. So when you look at wellness returns, you've got to look cumulatively, and I'll show you that in a second, because in the first year, you're not going to save any money on medical costs. But you will, because they've lost 0.5% a year cumulatively, or our employees are on average 2.5 pounds lighter than they would have been were they the standard person in America. And our chronic disease prevalence, looking at the 6 major chronic diseases that we followed, instead of increasing at 10% a year, and I'll show you what I mean by that, it's not a total increase, but you convert healthy to unhealthy as they get older. Instead of that, they decreased 3, 11, and 2% those 3 years. And this is our cost curve. We were on that red line. We are below the green line now, and I'm going to show you the actual data. So in the first year, all in, this is all administrative costs, all increase in pharmaceutical costs, every other increase in cost, we saved maybe $6 from our best competitor organization that we followed. It is not changeable it's not discernible statistically from anything else. So if you're just looking at 1 year, you're not going to save any money. It's trivial. And in fact, it costs more than that the first year. But as you accumulate, this is what's happened. So in 2013, we spent $395 per employee per month, all in, including the incentives, and we do have large incentives. In 2014, 397, and last year, 396. That's despite a now over 16% increase in actual pharmaceutical spending by the health plan, and despite our paying ourselves more for each day in the hospital and each provider care. What does that result in? Well, if you look at our trend line, it saves $241 million. That's real dollars. If you look at our best competitor, it's $156 million. If you look at what our CEO will say, what our CFO, there's always a battle between the CFO and CEO, our CFO will admit that it's $74.9 million over our best group of competitors. So you do save money, but it takes a long while to get there. So is a do-over? Yeah, it is. At what cost? The return on investment is now greater than 10 to 1, and we've spread it to other corporations as well. Who has to play the key role in it? Will the family? No. It doesn't in America. You can't do this with just intrinsic motivation and the current way America or any country in the world is going. Only 2.7% of Americans are doing even 4 healthy behaviors poorly. Will it be family and consumer science? That's what used to be home ec when I was going to school? No. The budgetary people have taken it totally out of schools. They don't even teach it anymore. Smartphone and apps do work for the healthiest populations who compete, but they don't change behavior of the people, of the vast majority of people. Docs and medical practices, it would work if we could get it done, but we can't even get it done. Employers and the government insurance company are the only ones who can grab people and give them enough incentive. So yes, what we do with our employees is if they hit those 5 normals that I showed, plus get their immunizations up to date, they get back to 2009 insurance rates when we started this, which essentially is a saving of 30% out of pocket in their costs, or virtually 0 out of pocket. But you have to do 6 things. Culture change first, and we repeatedly message. And it's fun messages. It is not do this because you're going to get healthy. It's do this so you can live longer or have better sex or whatever it is that you enjoy for fun. It is aha moments. If that guy can do it, I can do it. It is using 2 or 3 people every month in Toby's Connection, where he in fact shows how people have transformed their life by managing stress, transformed their life by losing weight, by getting rid of tobacco, by doing something else that's been healthy. And the problem isn't finding the 2 or 3, the finding is limiting it to 2 or 3 people. It is knocking down barriers and making it free. Yeah, it does cost you something in the first years, but the return on investment is great. And I'm going to show you, at least in some of the corporations where we've looked at productivity, you get that great a productivity gain in the first year. You don't get any absentee change. We couldn't track. When we looked at absentee change, there is none. But you get productivity. I don't know why I'm doing this. Productivity. There we go. You get productivity. Make it the easiest choice. So we don't say to someone, you can't have a sugared beverage. But we don't want it to be available there. You have to bring it in. We want a work environment to foster health, not foster disease. And then incent it big time. And yeah, we have an opt-out if the doc says that this patient can't get there no matter what I or she does to get there. And how many do we have? We got now 48,000 employees, a total of 101,000 people we cover. We have 31 people who have opt-outs on it. And it's not because more have applied. It's they don't need it. You can get there, because this isn't getting there by just doing hard work. It's getting there by doing hard work, by a culture, and by, in fact, whether you get pills or not. And we were very lucky. We made a ton of mistakes. This is not easy to design a right wellness program the first time. That's what we were doing, because there is no right wellness program. But we had to do it from scratch, and we made a ton of mistakes. It's pretty easy now. We publish it, so anyone can copy it. But We had a form that our HR system didn't talk to our medical record. So the employee had to bring a form into their doc that had, do they have blood pressure, diabetes, et cetera. And it changed the whole relationship between employees and primary care docs. So instead of not filling the prescription for statins, or not getting their blood pressure filled, or not managing something else, they then said, "Doc, get me to 5 normals. What do I have to do?" And it totally changed the relationship. So, culture change first, aha moments, knock down barriers, make it the easiest choice, incent it big time, and then you have to offer multiple programs. If we had only one weight program, we wouldn't succeed. You have to have about 10 in weight. Weight Watchers may succeed with 20% or 22% of our people, and coaching may succeed with 30%, our e-coaching, and maybe Curves with 5%, and maybe the fitness centers with 3%. But when you add up the 10 programs we have, we can get 70% of people to get to a normal BMI if they want it. We then take this, what we learn here, and we sell it to other corporations. So some of those corporations, Crum & Foster, 7 sites that they did this at, 7 sites they didn't. Their first year savings, this is their calculation, because they do in claims processing. So they look at productivity and processing. Only 6,000 of the 966,000 is medical saving costs. Almost all of it is in productivity changes. We work with these corporations. This is Lafarge's graph. Lafarge has a $40 million saving, they think, attributed to our program. And in fact, they do the whole thing. And so we have it on their website, but it also has a large incentive program with it. And it has those fun videos, if you will. But the first year they did it, they didn't do it in the normal people. So of the 100% normal, guess what happened? The next year, like everybody in America, 10.9% of their people who were healthy on the 6 normals developed a chronic disease. And that's what happens in America. At age 47, 50% of chronic disease, 50% not. Take 10% of these over here, 10% of these over here, and pretty soon you see how it adds up. So it asymptotes at 96 to 97% of Americans end up with a chronic disease at age 65 that is either untreated or undertreated. I showed you these before on easy things people with breast cancer or prostate cancer or colon cancer or joint health can do to stay healthy. And that's what we teach, in fact. So we have a series of programs, shared medical appointments, that not only work for our employees, but work for our patients, so that, in fact, if you will, in every part of the health system, you can't be touched without getting a program that helps you not need us for illness care again. That's the goal. So the goal was to learn what it took with our own employees and then to spread it to our patient populations and other employees. And if you say, where are we in stress? Well, we have a huge stress. This is 275 nurses. They are at a stress level which 5 years later, when the stress scale was developed at Carnegie Mellon, would cause chronic disease. 75% of them are at levels that would cause chronic disease when the scale was developed in 79 to 83, or was associated with development of chronic disease 5 years later, to appropriately say it. And now, with a program, they're able to reduce that 44%. And if you look at it from a standpoint, they're changing which of their genes are on or not. And what they're doing, they're also changing their burnout. So 44% report high burnout. They bring more energy to work when they do it. What is wrong with incentivizing, to a large degree, employees so they feel better, so they save money, so we can charge less for medical costs, and to save society so that we don't have to go rationing and we don't have more social inequality? I believe that if you design a wellness program correctly, you can spread it correctly, and you can rapidly change health in America and the world if you want to. And if we don't do it, we're in a shitload of trouble. Thank you. I'm an academic, so I've got to show this. I do have conflicts. I did write these books. I do earn royalties on them, so I hope you buy them, but they are a conflict. I did start those websites as well. We have a conference And I just want to go over what it at least took in our program and what it takes. If you don't have these 6 programs, if you don't have all 6 of these, don't bother with a wellness program. Because every place we study that doesn't do all 6 fails. Thank you.
Okay, we have about 3 minutes for questions, and then we're going to take a short break. I have one quick question, which is, if I heard you correctly, you said that your smoking cessation data or your smoking rates were not based on self-reporting. What were they based on? How do you?
They're based on cotinine in the urine.
So you're.
There is self-reporting, and then we verify it with cotinine in the urine.
Mike, isn't the great opportunity for you guys, particularly, but that is the next level would be wellness and reversal, because you have at the Wellness Center the ability with the Orange program, the SE program, to actually take people that have serious chronic diseases and reverse and stop their diseases.
Yeah, even the CDC last week studied with the simple program that they've got at the Y called Diabetes Prevention, the YDPP, showed that you could take pre-diabetics and get them to, at least a large number of them. It's a relatively, what I would call, inexpensive program to take pre-diabetics who actually have the pre-diabetes, and instead of progressing to diabetes, they progress to health. So you can do, and you have to do that, because as the data showed, in fact, it is that group that is the largest savings as you get to take them from the pre-disease and early disease state. So 60% in our program, as you know, 60% of the people with diabetes, not just pre-diabetes, with diabetes, we're able to get out of that. And you do know the data on coronary artery disease, it's similar. There's a major difference, though, and I want to stress the major difference. In illness care, what most medical institutions do now is that's the physician doing something to the patient. That is, I give you a pill or I do an operation on you. In wellness, the hard part is the behavior change, because it is the person doing the work. It is the employee doing the work. So you've got to make it as much fun as going to Disneyland or whatever. It's a treat to be able to do it. It's a privilege to be able to do it and not spend that money. And part of that, at least in our program, has to be put the incentive in. By the way, those dollar figures I showed you, I want to emphasize one more. They include every penny of administrative and cost in the structure that has gone down. That's why I have some fairly significant data. We have changed compared to our competitors. Even though we're paying more, we have less chronic disease, which is the key. So I'm inviting RAND to, if you will, study it so that they can change at least something they write about.
A technical question and then a question about, the technical question is, you said employees saved 445, lost 445,000 pounds?
That's the 34,000 we've tracked linearly, yes.
So that's over 10 pounds an employee?
Yes.
Okay. Over what time period?
It's cumulative. That actually data is from 2000 and either December 2009 or December 2010, I apologize, through December 2014. It's still ongoing. We just don't have the data accumulated.
My other question is on what we can take about the replicability of what the clinic does. And so the two concerns I would raise or have is, one is...
That's why I showed you the 40 corporations we're replicating it.
One is that certainly part of what the Cleveland Clinic has done is also changed its employee selection. Right? So the Cleveland Clinic will not hire a smoker, and individuals that don't quit are, I believe, suspended.
No. In the employees, we do not, since 2008, we don't hire, actually it's September 2007, we don't hire smokers. Right. If you are a smoker and you don't smoke on campus, nothing happens to you. If you're a smoker and you smoke on campus, you're given opportunity to quit. If you don't, then you're terminated.
So that would suggest that
And by the way, the only two people we have terminated from that are two physicians early on who refused to quit smoking in their office. So we demonstrated that we were serious about it.
Right, the question on replicability would just be, that would suggest the Cleveland Clinic's employee population is not representative of the population as a whole. And so, while that's great for the Cleveland Clinic and cost savings, those folks may still be
And
out being less healthy
I can tell you that
elsewhere.
I can tell you that now, I don't know the number, but I know it is over 500 other hospitals have followed our lead in not hiring smokers.
Right, so those folks now are working in convenience stores instead of hospitals,
No,
but they're still
the
smoking.
smoking rates in the country have gone down significantly. Over that period, they've gone from 22.3%. Last year, in fact, the CDC upped its smokers because it was so low. They went from 17.2% to 15% in 1 year. They didn't believe the data, so the official data is 16%, but it has gone from 22. So we are getting, and there's no reason we can't get smoking out of the population. So, I mean, just to say you should not do this because it disadvantages smokers, well, maybe we should disadvantage anyone who produces cigarettes and who smokes, because in fact, it's a bad thing.
Sure. The question is just whether or not there's cost shifting as opposed to overall societal savings. I think there's a question in the back, and then we have to stop.
Yeah. It'll be quick. It's just one question on each of the slides, so that won't take too long. No, I wanted to follow up on the smokers question. So I like that you are really interested in also learning from your experience, and a lot of this is data-driven. So I wondered if you could say something about the effect of the non-hiring smoker policies in terms of helping people quit. Is your experience that people have actually then quit to work here, or are they just looking for other employment? So that's the first question. And the second is, you said rightly, this is difficult to change this behavior, but why not also not hire obese people?
Let me deal with the first question first. We know of 71 people who came to the Cleveland Clinic to get free smoking cessation. That is, you can apply, if you apply for the job in that era, that's before the 2010 law, that required insurance companies to have smoking cessation or tobacco cessation programs in their plans. But before that, they didn't. And we knew of 71 people who came to the Cleveland Clinic, applied for jobs, were qualified for jobs, went through our smoking cessation program, and then didn't come to the Cleveland Clinic after they had successfully quit. So we assumed that they had only applied to get the smoking cessation program free. So I only know of that, if you will, that's those 71 people. I don't know of what else it has done other than it's pretty well advertised. But we still do have people who test positive on cotinine tests after they've otherwise qualified for employment. When we're about to offer them jobs and get their pre-employment physical, they smoke out, if you will. Those people get the chance of quitting and getting put in the employment pool again. We think only 2 have done so in the last 3 years. So we don't get many people who smoke applying for jobs now. Second question is, why not? That's one, it's not legal. And 2 is we think we can help people change and get healthier. So that's part of our goal. And part of our goal isn't to do anything that gets rid of any population. There's a shortage of qualified healthcare employees and nurses, as you know. And so, but we think we can help them get healthier and live more satisfying lives the rest of their life.
All right, thank you very much.